Hey there, I'm Dr. Charles Wong, and I am an ER physician and home care physician. I'm here to share my experiences on how successful seniors and families age at home. And so I work for and have co-founded actually this company called HomeFree Home Care. And that's how we've acquired this experience that we're going to be sharing with you guys here. And this is just to disclose that this role with HomeFree has nothing to do with my other affiliations with Alberta Health Services and the University of Calgary, where I hold other roles. So in the course of this talk, I hope to leave you with the following objectives. So we're going to help you define successful aging. We're going to discuss the basics of facilities and home care, the kind of nomenclature, the terms that are used around it, as well as the basic costs. And then we're going to go into the meat of the talk, which is the lessons that we've learned as a home care service as to how successful families age at home. And finally, within that, we're going to talk about this novel program of medically supervised home care, which most people have not heard of, and how it is keeping seniors thriving at home for life by replacing facility-based care. So this is a recording, but you can actually, even if you're watching this as a recording much later, text this number for any questions about anything you hear in this presentation. We'll be happy to get back to you. So who am I and why do I feel qualified to talk about this topic? So I have worked for over 10 years now as an emergency room attending at the Rocky View Hospital here in Calgary, and day after day, seeing thousands of patients and experiencing the same thing over and over again, namely watching patients and families who are burning out with care at home and suffering what I felt to be avoidable consequences of their chronic conditions and being admitted to the hospital, mostly against their will, in the sense that they would much rather be home if they could. And this has led to not just individual and family tragedy, but also a national tragedy, which is that our hospitals from coast to coast are completely overwhelmed with admitted patients who can't get home. And this backflows into our ER hallways, which I work in every day, or used to work in every day. Now I work in part-time. And it's creating a crisis of hospital capacity, which affects every single person accessing ER resources. So I decided that I could do something different to try to help these patients. And so I started a home care firm called HomeFree. And HomeFree is getting patients like this one here, who allowed us to share her image and story with permission, out of hospital and facility when they were otherwise doomed, if you will, to long-term care or nursing home. So this patient I met when she was bedbound at an AHS facility. She went in there for an elective surgery, walking, but then weakened considerably after the surgery due to some chronic underlying issues with her muscles, and then got to the point where, due to the very limited rehab facilities and resources available in the hospital, weakened to the point that they essentially felt that she would never go home and put her on a list to go to a nursing home. And they met us. We applied our program of medically supervised home care, brought her home, and now she continues to thrive at home with actually not even the walker to get around many days and mobilizing independently on her own. And so she's not unique. We've offloaded thousands of acute and long-term care bed days from our hospital system in our first year alone in 2025, and we hope to continue to do multiples of that going forward into the future. This program has been recognized by the Alberta College of Family Physicians as a top innovation, and so it is well established by the medical community and esteemed actually by the medical community. So our first objective is to define successful aging. So how we came up with this definition is essentially talking to hundreds of people and asking them, what are your goals as you age? And the vast majority of people are telling us these 7 things. They use different terms, but these are the common concepts, the common thread that connects all of these families and individuals, no matter where they are with their disease, what their socioeconomic background. So most people want to be at home. That's fair enough and easy enough to understand, as opposed to a facility. Only a very small minority of patients really want to go to a facility. Although many people assume they have to go to a facility, they still prefer to be at home. Most people don't want to be a burden to their family, whether it's their spouse or their children or grandchildren or anyone else really. They don't want to be a burden. And I had a debate with my team as to whether or not we wanted to use the word burden. It seems a little bit harsh to describe someone who's experiencing chronic disease or needs help. But the reason I chose the word not to be a burden of this term is because this is how most patients tell me how they feel. They say to me that I don't want to be a burden to my wife. I don't want to be a burden to my kids. And so that's a common thing we hear, and that's number 2. Our patients want to maintain their relationships as well as their meaningful activities, and these often go hand in hand because relationships and activities are tightly connected, even more so as we get older. And that straightforward enough. They want to preserve autonomy. They want to achieve the above, but they want to do it on their own terms. And believe it or not, it is possible actually to have the above, but not on your own terms. They want to, when they imagine themselves aging successfully at home, they want to preserve physical and cognitive function. This is basically being healthy. And I'll just point out that this is not the focus of my talk here today. This is not a longevity talk, but it's an important part of aging at home. And then, of course, they want to do so as long as possible. They want to live a long life, not just a short one, as long as possible. And what's the alternative? So the opposite of all those things are forced institutionalization, caregiver burnout, which is a medical term, social isolation, which is being alone and disengaged from activities. Again, going hand in hand with social isolation. Loss of autonomy, so things being done to them or for them or supposedly in their interest, but not on their own accord. Physical and cognitive decline, which is getting sicker and weaker, more and more demented, and losing control of one's mind. And then accelerated decline is just a kind way of saying dying prematurely, which happens, sadly. So the basics. This is basically the part of my talk where I'm going to go over the nomenclature, the costs, and sort of the base. You hear people talking about in the news, or you've heard it from families or friends who've gone through this, and just to get it all out there, because a lot of these terms get thrown around and people don't always know what they mean. So when we talk about acute care, we're essentially talking about the hospital system. So that's the literal hospitals themselves. In Calgary, we're talking about Foothills, the Arthur Child Cancer Center, the Children's Hospital, the Rocky View, where I work, Peter Lougheed and South Health Campus, as well as their adjacent kind of facilities like urgent care centers and the rehab centers that patients go to after they get surgeries and after they are done with their acute care. The alternate level of care designation is basically a patient who's in an acute care facility, usually a hospital, and has been deemed to not be able to go home and is waiting for a long-term care bed. So essentially it means that they no longer need acute care, so they're not there for the main purpose of being in the hospital, which is acute care, and so they have therefore an alternate, a quote-unquote alternate level of care. And so the other term that's used in the media to describe these patients are so-called bed blockers. They don't really need to be in the hospital, but they have no alternative. Bed blockers. An unkind term, obviously we don't use that to describe people directly, but it is used in the media and it's well understood. And it's a huge problem in our society, as I pointed out early in my slides there. Because bed blocking patients actually take up scarce beds that patients who really need acute care would otherwise need, and that backs up into ERs, which means that ER wait times get longer largely because of this problem. So it's a problem that affects all of us. Outside of acute care, you have continuing care, and these are the sort of facilities that people talk about when they talk about going to a facility. So the lightest stage is independent living. So that's your average retirement home. This is essentially the same as an apartment building that's directed towards seniors. And so that you're around your peers. There may be a couple of services or things that are more appropriate for seniors, like the exercise room, and the activities are directed towards seniors. And then you have assisted, otherwise called supported living. So this is essentially usually owned and operated by a large company where they both own the building as well as all the services inside that building, which help take the burden off of individuals and families. So they're usually providing meals is the main thing, as well as activities and social gatherings. And then to a much smaller extent, they provide some care support. So nurses and care aides to help with daily activities and simple medical tasks. If your needs are higher than that, then you go to what's called a long-term care center, or LTC, sometimes called a nursing. A sub-segment of nursing homes and long-term cares is called dementia or memory care, which are usually locked units, meaning that their doors are literally locked so that people inside cannot escape, which is a symptom of dementia. And both assisted living and long-term cares can be either public or private, although all independent living facilities will be private. Hospices are a subsegment of long-term cares, essentially, where people have an estimated life expectancy in the order of days to weeks, sometimes just a few months. And so it is a very specialized type of 24-hour nursing and physician care, which helps people to palliate so that they can have a comfortable final days to weeks of their life. So the public facilities that you're probably familiar with are these names. They're named after people. They're also sometimes named after the big conglomerates that own groups of these facilities, like Care West or Aged Care. And these public facilities, surprisingly to many, are not free. to the patient. There is a copay that patients pay in the range of approximately $70 to $100 per day. So on the very low end for a shared room at a public facility, the copay is about $500 a week or over $2,000 a month. So this is a fact that people often don't realize. Public long-term cares are not free. Now, public facilities do include with that fee their meals, housekeeping, and some healthcare services, which is very important. But usually we're looking at still thousands of dollars per month, anywhere between $2,000 and $3,000 per month. And the costs can escalate significantly from there if care needs are significant. So basic healthcare services are covered at this rate, but it gets much higher, and you can pay easily double that even at a public facility. Now, private facilities go by these names in Calgary. There's probably others that I've missed here. Riverwalk, the Edward, the Manor, Verve. These are usually owned and operated by big conglomerates as well. Sometimes they're independent facilities where there's a single owner. They're well appointed. These are usually the kind of nicer places that people imagine themselves going to, with nice swimming pools and activity rooms and bars with nicer food, etc. They're expensive. $7,000 a month is typical. If you're in the memory care segment of a facility like this, it's easily in the 5-figure per month range. And that is without adding on extra costs for care. So that is the base cost for the facility and the activities, and just a nominal degree of support. Anytime you need additional support, it's usually charged hourly, and it's sometimes in 15-minute segments, like a lawyer basically, and it can add up to thousands of dollars more per month. Now, for staying at home, you basically have 3 types of home care. There's the traditional home care, which is what's provided by our Alberta Health Services, now called Assisted Living Alberta system. That's the default when you call the home care line. And then if you don't want the default, you have your options of private home care, standard private home care, or what we can now call medically supervised home care, which is sort of advanced home care that replicates facility level care in the home. So here's another fact. All home care is privately delivered home care. So there is no such thing really as a public home care system. Almost all home care in this province and most provinces, if not all provinces, is outsourced to large conglomerates that compete on cost and volume. And so the common thing we hear basically is that there's endemic workforce burnout, costs are driven down, the quality of the services are relatively low. This can be useful when providing large volumes of very simple services, but it is limited. Now, the flip side of privately delivered home care is that most home care is still publicly funded through a private deliverer. So again, traditional home care limited by the fact that they're mainly meant to perform really brief targeted tasks like helping put on some clothes, getting your medications given to you, or changing a catheter, for example. But these tasks typically last between 2 and 15 minutes, so that your average home visit is less than 5 to 30 minutes. And you usually get a stranger come to your house to do this task because, again, it's a volume sort of service that the provider sells to the provincial health authority at huge volumes. The problems that we hear about this are the variable providers from person every day, irregular scheduling, being told that your 5 or 10-minute visit is going to happen sometime between 8 a.m. and noon, which is a big window. And then, of course, the lack of direct control because the provider doesn't work for you, the patient, they work for the government health authority. We also hear that there's significant language barriers, often even with English, and that there's no physician support. So anything difficult or medically significant happening in the home is not dealt with by the providers that they send, which are usually HCAs without any additional support. The next fact is that home care has no meaningful standards nor regulations. So unlike continuing care facilities, which are quite heavily regulated, home care is very, very poorly regulated, almost non-existent regulation. And so almost anyone can call themselves a home care provider. You don't have to have any special training, certification, or accreditation. And the result of this is that the consumer is confused and doesn't know what they're getting and doesn't understand the quality of the work that they're getting. Private home care is the alternative if you don't want the kind of brief visits that the government will provide you. And many families will have experience with this. Essentially, you're paying for hour-to-hour support for either HCAs, LPNs, or RNs, and their kind of relative costs are there, which reflects the market worth of these individuals. The basic problem with this type of care is that, again, home care is poorly regulated, and the physicians that operate in the health system rarely, if ever, intersect with home care. And so there's almost no physician support. Costs of this, depending on one's needs, can range from the hundreds to the thousands, and sometimes even tens of thousands of dollars, depending on the volume of care per week. But the vast majority of people are spending hundreds of dollars per week for home care, not thousands. Now, different types of home care have their various pros and cons. Before I get into medically supervised home care, I'll just point out that there's a program called CDHCI, which allows public funding to pay for privately delivered home care. So medically supervised home care is the work that we do. This is how I learned about home care and how we deliver care in the community. And so we get public funding support, starting costs in the hundreds of dollars per week. The system is integrated into the health system so that the doctors and nurses looking after you are connected with the hospitals and family doctors that you otherwise also have. There's assistant providers. They do a much wider spectrum of services that can include things like taking you on, getting you to your medical appointments, picking up groceries, helping with the cooking and cleaning at home, and language matching, which is a huge one. So for sure, if English is your language of choice or your first language, you get an English-speaking provider that speaks adequate English, but also if your first language is Cantonese or French or something else, it can be matched to your specific needs. And this is information about the client-directed home care invoicing program. So if you want to scan that QR code, you'll be able to see more information about how you can get publicly funded home care through a private provider. And so the AHS CDHCI program funds a certain dollar per hour, and then you get to choose which provider you want to direct your funding to. And the fundamental difference there is that you get to choose your provider, and your provider therefore works for you rather than the government, which really totally changes the value proposition of what you're receiving. The CDHCI assessment process is difficult. There's variable outcomes. If you want to go down this pathway, have a chat with one of our team. After this, we'll explain how this process works, but essentially you call AHS, you get a case manager, you ask for the assessment, and then you do the assessment. Simple, but difficult. Always requires a family member to support. The patient themselves can never get through this on their own. So now to the meat of our talk. So how successful families age at home. And these are the lessons that, again, I have accumulated over years of working as an ER doctor, as well as now transitioning to becoming a home care doctor, where I've been in the homes now, sitting side by side with families and patients in hundreds of homes, just learning from them and trying to help them to the best of our ability. So these are our success factors. I'm just going to be going through the success factors and noting the principles and the patterns that I see in successful families. So the first success factor is be at home. So successful seniors know they can age in any home. So that means that it doesn't matter if you live in an independent living facility, maybe you've already made the choice to go to a facility, or if you're still living on an acreage down in Okotoks, or if you have a large single-family home somewhere in southeast Calgary that backs onto a lake. We have not seen a situation yet where a senior cannot age in the home that they're in without appropriate supports. So any home. And then the second thing is, further to staying at home, is that they challenge the assumption that society and even healthcare providers have that when your condition or your age reaches a certain point, you need to go to a facility to be safe. And that's just not true when you really break down what a facility actually offers and what your problems actually are. And one of the common things that we hear from families is that, well, I've been a perpetrator of this problem too many times to count. The so-called road test. So when you're in a hospital and you have any sort of ailment, let's say it's pneumonia, you're there with a chest infection and you need antibiotics, and you're 85 years old, the doctors and nurses are going to do what's called a road test on you, which is to ask you to basically stand up and walk around the room and see how long it takes you to get out of bed, stand up, and how safely you can ambulate. And that's basically shorthand for how safe you're likely to be when you go home. And if you fail the road test, which is their interpretation of, oh, you might fall, oh, you can't climb up the stairs in your 2-story home, then the assumption is that you cannot thrive at home and you will have to stay in the hospital. You fail the road test, you get admitted. And this line of thinking is one of the major reasons why we're in this bed block situation in the hospital right now. Our healthcare providers really don't think outside the box. And again, I'm super guilty of this. I've been a residency program director for years. I taught residents to do this. And we never challenged the notion that, yeah, okay, maybe Mr. So-and-so can't climb the stairs in their 2-story house, but maybe they don't need to. You know, yeah, it's a little bit inconvenient, but compared to the inconvenience of staying in hospital, which is not only inconvenient but dangerous and costly, they'd be willing to make accommodations to live like that. So I wrote this article that describes this problem. If you want to Google it or QR it, you're welcome to. So a question we often get from families is, what kind of modifications do we need in order to thrive at home? And so really there's very few. Like even if you didn't have one of these fancy bathtubs, which could cost between ten to $20,000 to install, which is very good if you can afford it, but it's not necessary. There are other things that you can get to solve this problem. And for the most part, you also don't need a stair lift, although a stair lift can be useful if you live in a two-story home. But most people will eventually either downsize their home or just move all their living to the main floor. Now, the reasons that we like these types of showers is that it makes it very easy for people to help you. So low tripping hazards, there's not much of a lip here, there's no lip here climbing into it. There's a seat here. This one doesn't have a seat, but you can easily add a bench. And there's a wide bay where a person helping you can step in and help you shower. And so we really like these types of showers. So you just need a shower, really. You don't need a really fancy adaptable bath like this. Although this is also really nice because the seat is built in and there's a lot of space up top in order for a person to help you. But it's actually harder to help a person in and out of this than it is this seat here. And this is just another example. Nice bench here. The problem with this one, by the way, is this lip here. Fairly tall and also long lip. So you have to lift your leg quite a bit. For an older person with any sort of neuromuscular disease or hip problems, that can be a significant tripping hazard, as well as the fact that this tile floor looks really hard and lots of places to hit yourself if, heaven forbid, you were to fall. Stair lifts, I see very few of them. The biggest problem with stair lifts, I think, is that they just scream disability. I think people don't like having them in their homes, so they don't get them. And the vast majority of people actually can do stairs even when they're quite frail, as long as they have the proper support. And in fact, doing stairs and forcing oneself to do stairs, going up and down with support, is an important way of maintaining mobility. And this is just a couple of other examples of stairs. Much easier than installing a stair lift, and probably providing a significant improvement in safety, is just addressing slippery stairs. So slick hardwood or even slick carpet can be adapted with things that you can stick on or change the flooring. And then of course these sticky socks. I love seeing seniors wearing these sticky socks because I've worn them before. You feel like Spider-Man. You basically will stick to anything, and it really reduces your risk of fall, especially on stairs, significantly. Further to staying at home is this underlying assumption that all of society has, that all seniors will end up in a facility at some point. And so successful families don't assume that. They don't overestimate their need for facilities. So what are facilities? They're basically a place where people can get 24/7 access to care or availability of care. But the vast majority of people who are even at facilities, and I work at multiple facilities, the vast majority of people who are at these facilities don't actually need 24-hour care. They just don't. And the other point is that just having access to 24-hour care doesn't actually mean 24-hour care. And it is not uncommon, especially at public facilities, where you're at a place with so-called 24-hour care. Again, that's 24-hour availability of care. But the actual volume of one-to-one bedside support for a patient is usually in the order of minutes a day, not even hours a day. You'd be lucky if you're a very high needs patient to have 2 or 3 hours a day of bedside support. It'd be rare, honestly, quite rare, because staffing ratios just don't support that type of care. And so it's a huge misnomer to assume that you're going to get a large volume of care at a facility. And in fact, many facilities outsource their care to home care companies. So you're essentially doing the same thing you'd be doing at home by hiring a home care company, but you're also paying a facility fee. And that's actually a significant proportion of the work that we do. And so knowing this, successful families choose to hire help into their home sooner rather than later. And this reduces their immediate costs, but also their long-term costs by preventing potential complications of being at a facility. So they're bringing the facility to them. And what does this help look like? Well, it's different for every family, but one of the big things is eyes in the home. So a lot of families, children, especially and grandchildren, will spend a lot of their time going to mom's or grandma's home to check in on them. And that's a great thing to do, by the way. You should continue doing that, but it can sometimes be burdensome if you have an appointment or you have a kid's activity and you have to make sacrifices to make that happen. So having some additional eyes in the home to support that is important. And then it's all the regular things: groceries, cooking, cleaning, medication, medical support, and then the coordination of all those things, which is a job on its own. It is literally a job because we hire for that job and we have people that do that job. And by doing this, it allows family to be family. So sons and daughters can be sons and daughters again, rather than caregivers. And so this brings us to our next success factor, which is not to be a burden on the family. So successful families prevent and treat caregiver burnout. They recognize it, and when they recognize it, they do something about it. Caregiver burnout is actually the number one reason why anyone goes into a facility, in our experience. Now, of course, caregiver burnout happens when there are diseases in the home like dementia, Parkinson's, frailty, osteoarthritis, injuries, etc. But the common endpoint of all those diseases in the home that leads patients in the home to end up in a facility is when the care team, the daughter, the spouse, the rest of the care team is no longer able to manage that condition in the home. And then that patient is then forced into institutionalization. And we see that in the ER all the time, where really nothing fundamentally has even actually changed in a patient, but the family has just had it up to here. I mean, maybe that's the wrong way to put it, but like they are just totally overwhelmed, often in tears, just breaking down themselves mentally, physically, and emotionally. That's caregiver burnout. So successful families don't hide their issues. They uncover and deal with them. So it's really important for sons and daughters and spouses to talk early and often and be honest about how the caregiving burden is affecting them personally. And one of the main things that we do as a medically supervised home care service is we go into the homes and we perform something called a family meeting, where we sit down with families and we always insist that where there are kids and other caregivers involved, that they're part of this family meeting. And then we have a powwow and a big discussion about what's going on in the home and get everyone's perspective on it. And almost inevitably, we're uncovering by being there and hosting this sort of like therapy session, we're uncovering feelings, thoughts, and perspectives that have been unsaid that needed to be said. Like a common one that I'll often say it and I'll have the family affirm it if it resonates with them is that a son or a daughter no longer enjoys visiting their parents anymore because when they walk in that door, they don't know what they're going to walk into. Has the garbage been taken out? Am I going to find mom have not taken her medications again? Am I going to find her in a confused state? Are they going to be soiled? What kind of work is there going to be for me when I walk in there? And that causes them to not want to go there. And that causes resentment and relational separation, which is tragic and sometimes irrecoverable when it's crossed the line. So addressing that and bringing it up for discussion is a really important first step to being able to help those families. Eventually, families have to reckon with the fact that these little things add up. And I'm going to show you a slide of the spectrum of caregiving support that crosses the line from being a family member to being a caregiver. But of course, I'm in my late 30s. My wife and I help each other. She occasionally brings me a cup of water and I'll make her lunch, etc. These types of normal day-to-day things of helping each other are normal when it's once in a while. But when you do a little bit more and then a little bit more and a little bit more, it might sound like nothing. Oh, bringing you a cup of water is nothing. Oh, helping you to the bathroom is nothing. But it adds up to a point of actually causing burnout. And so recognizing that these little things adding up is a big thing. And then drawing a line between being caregiver and family. So here we are. This is kind of a list from top to bottom of like normal things we do for our families and for the people that we live with, and up to the things that become less and less normal to the point of being like a professional job and a full-time job. So activities and companionship at the top, that's basically hanging out and being family, that's normal. We share meals, groceries, we take care of each other, that's normal. But then when we start having to take care of all the laundry, of course we have to do some of our own laundry, but when all the laundry falls onto us, all the housekeeping falls onto one person, and now the patient requires help getting dressed every single day in the morning and the afternoon. They soil themselves, they have to get redressed. Now they need help with their baths. Now they need help toileting. Now they need help doing any kind of movement or even just walking around the home. Somewhere along this line, a caregiver crosses the role from being a family member to being a caregiver. Now, where that line is, I'm not going to say because it's different for every person, family, and situation, but at some point it definitely happens. These little things add up, and that's when caregiver burnout happens. Successful families recognize this and they make a point of recognizing and maintaining this caregiver family separation. I won't say much more about this maintaining relationships other than that we find when we go into homes that the more people are involved in a family, the more time families spend together, the more involved the kids are and the spouse is involved, the more likely a patient's able to stay thriving at home. This is obvious. I don't have any specific relational advice. This is not my area of expertise. But I will say that definitely having people in your life is a huge success factor. With respect to maintaining non-family relationships, I find that a lot of our really successful families, the individuals treat retirement like it's a job. They have something to do every day. They actually resist care partly because it gets in the way of their day-to-day routine. That routine can be anything from golf or a book club, or just going for their daily walks at the mall. We have a guy who loves going to the mall, Market Mall, to go for his morning stroll. He's a mall walker, gets his A&W, people watches for an hour and a half, and then goes home. That's his thing. And that's important. And it actually engages them with society, and even if it's just stranger interactions, that social engagement that matters. Um, and then the flip side of this too is there are people who actually enjoy being at facilities. If you're the sort of person who loves like cruises, for example, you're gonna love a facility because it's like a cruise. There's like a daily schedule every day of the activities that are gonna happen. But successful families, if they know this about themselves and they want to go to a facility, they do so when they can still take advantage of it. And not everyone can. I would say when I observe the population of facilities, like the large majority of people that end up in facilities are not able to enjoy the vast majority of the amenities. In fact, when I go to these activities and I see them happening, like they're really undersubscribed, is my opinion. Like there's almost nobody shows up at the activities because they're all kind of past that stage by the time they get there. There was a great anecdote that I had. One of our first clients that we took home from hospital, he'd been there after a fall. He was stuck in hospital. We got him home. It took a while to rehabilitate him to his baseline mobility, but when he was finally able to walk independently again, we were able to take him to, I forget the name of the grocery store. I think it was Sunterra. And Sunterra has like, it was Sunterra. It has this little like cafe, at the front of the grocery store. And when we finally brought him back there with a care provider and he'd be gone for a couple of months, all his old timer friends were just so excited to see him again. And so that's what this picture is meant to depict, is that it doesn't matter what your social circle is. It could be as simple as a coffee group at a Sunterra. It's really important. And it was such a beautiful experience seeing our patient reconnecting with his friends. It was like a scene out of Cheers. Everybody knew his name. They were welcoming him back, asking him where he'd been. And so that's the kind of goal we have for our families and patients when we try to help them thrive at home. Meaningful activities, by the way, are almost always tied hand in hand with relationships. As sadly as our seniors get older, their friends start to pass away. And if you're really old, like some of our patients, like literally 99 to 100 years old, it becomes that you have very few peers left due to the obvious reasons. And so it's really important actually to make new friends. It's hard to make new friends, I think, when you're in that age group. But we do encourage our patients to get out there, and even if it's uncomfortable, even if it's sad, sometimes to just put yourself out there and make new friends. Because when you have friends, you have activities, you have things to do. And if you don't have friends, you don't have activities or anything to do. Autonomy is the next success factor. Take a look at this. Does anyone recognize these lyrics? So this is, of course, the immortal words of Mr. Frank Sinatra from his song My Way. Actually, it might have been someone else's song that he covered, but in any case, the point here in this song, which is immortal, is that for a lot of our patients, for all of our patients, for all of us, it's more important to do things our own way than it is to do things the perfect way. And so what does that mean in terms of how we manage risk or decisions at the home? It's that the vast majority of successful families and seniors are actually much more willing to take on what we'd consider risk, in favor of their independence and autonomy. And I have to remind children often who are looking after their parents that if someone in their 80s or 90s, your parent says, I would rather die than do or not do this or that, then we should actually take that literally. That's no longer a figure of speech when you're in your 80s and 90s. When you're in your 80s and 90s, I think you're constantly thinking that every day could be your last, every week or month could be your last. And you really weigh the importance and the value of the things that you do with that context in mind. And so if a person would rather go home and take on additional risk of being at home, quote unquote risk, than being at home, than being in a facility, we should really take that seriously. And actually, the paradox is that it's the being able to do things your way often is actually wise, and paradoxically leads to better outcomes. That being said, older adults do sometimes do and say things and have preferences that can be difficult to reconcile in logical terms. Just an example of that might be someone who refuses to take a shower. You know, which can the cost and the inconvenience of the shower is low, the benefits are high, and it can be difficult to reconcile that. So when we're coming into a meeting with a person who is really, really strongly opposed to some intervention. Often the intervention is just simple help in the home to prevent complication or to help them with things that they obviously need help with. We frame the support in a way that the patient can understand. And the thing that I find patients understand best is that this, although it may seem like it's interfering with your freedom in the moment, it's actually increasing your overall freedom in life over a longer period of time. So if you allow a caregiver to come in here to help you with your meals and your laundry, you will be able to survive healthily in your home for longer. If you allow someone here to help you with your showers and bathing and routine so that your child, don't have to do this for you all the time, it will allow us both to maintain a healthier relationship and also help me in order to thrive as your son. And I didn't put that here, but framing in terms of supporting family is something that resonates with a lot of people as well. Successful seniors fill out their goals of care. They have conversations about this early and they know what they're talking about when this gets brought up at the bedside. So, do you guys have a goals of care green sleeve? Do you know what it is? It depicts this. This is what the goals of care represent. There's three basic levels. This is the purpose of the goals of care is to tell a provider what your preferences are if you're not able to say your preference yourself. This is in the case of you're unconscious, your heart stopped, or you're no longer corpus mentis, you're delirious, you've lost your ability to think or speak. And so, of course, if you can think or speak, you can just say so in terms of what you prefer. But some of these things are you'd be intrinsically unable to. For example, if you need chest compressions, that means you're clinically dead, essentially. So there's three basic levels of care. Resuscitative, which is kind of the do everything care. Medical care, which is the sort of what used to be called DNR, so do not resuscitate, so it's not resuscitative care. And then comfort care, which is end of life care, where we're doing nothing but keeping the patient comfortable. Now, the vast majority of older adults would prefer to be M level care. I'm not trying to tell anyone what to choose for themselves, but I'm just saying that if you're, as a frame of reference, the vast majority of people choose M level care. That's a DNR. So that's do everything except for the super invasive stuff. I don't want chest compressions. I don't want intubation, which means putting a breathing tube down your throat. The other way that people understand that is putting them putting them on life support or attaching them to machines to keep them alive, which is what an ICU is. Okay, so if you don't want resuscitative help, you don't want machines to keep you alive, you want medical care. And that means we'll do everything else. We'll do IV antibiotics, we'll do even simple surgeries, we'll do investigations to look for cancer, treat cancer, chemotherapy, etc. So you can do a lot with medical care by excluding resuscitative care. And then comfort care is sometimes also a misnomer because people think that I want to be comfortable, therefore I have to choose comfort care. No, comfort, symptom control, which is comfort, is throughout these levels. Okay, so just because you accept medical care or even resuscitative care doesn't mean we're not going to take care of your comfort. Comfort care means that you only want to look for comfort. You no longer want to chase down the cause of your disease. You no longer want to intervene in a way to try to prolong life. This is when you've accepted that whatever's happening to you is terminal and it's time for you to focus on just comfort. So this is usually end stage cancer, end stage heart failure, COPD, where we're talking about days to weeks to live, sometimes months to live. Any questions? And this green sleeve will depict this. This sheet here will say R1, R2, R3, M1, M2, and you click it, a doctor signs it, you put this green sleeve on your fridge, which is the first place a paramedic will look for your predetermined wishes if they come to your home in an emergency, and you bring it with you anytime you go to a hospital or a clinic. So preserving physical cognitive function. This is not a longevity talk. I'm not an expert in longevity. I'll just tell you what I've observed. You've probably heard this. Successful seniors walk a lot. They walk all the time. And walking is kind of a paradox sometimes because people do fall as they get older. There's a lot of reasons people fall. Their eyesight's not as good. Their muscles and mobility is not as good. Their vestibular system, their balance system is not as good. So all these things add up to falls. And the reflex that a lot of families have sometimes, especially kids and even doctors and healthcare providers, is to ask people to stop walking so much. Let me get that for you. Or don't go to the store this afternoon. That's too much of a hassle for you. I'll bring you the milk that you need. And the problem with asking someone to not walk is that it would actually, in the long run, it actually exacerbates their inability to walk and puts them at a higher risk of falling long term. There is no stage at which not walking is better than walking. Okay, so as soon as you stop, you use it or lose it, right? So as soon as you stop walking or walk less, you're actually going to fall more, paradoxically. Now, that being said, you have to do so safely. And so successful families are compliant with things that matter, like mobility aids, where the cost benefit is it's clearly in favor of using the mobility aid. Walkers are super important. If you can benefit from a walker, have one on every floor so you're not hauling it up and down the stairs, and use it even inside the home. The vast majority of falls, by the way, happen in the bathrooms. Oftentimes, people choose not to use their walker to go to the bathroom, especially at night, which is also the most common time people fall. So use the walker, especially at night. Put it by the bedside and be disciplined about it, and you will prevent a catastrophic outcome. Falls lead to complication and death on a regular basis, and it seems like a minor thing, but it's not. The other things that to preserve physical and cognitive function are being compliant with hearing aids, exercises, and just the simple things like medications and appointments. Now, the evidence-based strategies for cognitive longevity, this is preventing and slowing down dementia. These are all kind of the common um, everyday health things that keep you healthy in general. So control of vascular risk factors, that's like your high blood pressure, diabetes, high cholesterol, taking your meds for those things if you've been prescribed them, exercising, a diet full of whole foods, especially. Of course, cognitive stimulation, same with walking, use it or lose it. Social engagement speaks to the same, which is using your mind socially, which is an important way the mind works. Sleeping adequately, which does become harder as we age, but there are ways to improve it. Reducing or quitting alcohol and smoking, and then medications, of course. So medications specifically referring to medications that have been shown to potentially help dementia. Now, there's no pill that's really very good for it, but there are some that sometimes have been shown to slow it down very slightly. I will say regarding alcohol that although it's been said many times that there's no safe amount of alcohol, I do observe that a lot of successful families do actually enjoy a glass of wine fairly frequently. That's just my personal anecdote, and I choose to believe it. So for as long as possible. So this is not being forced to act before you have to, and living as long as possible. So successful families act before they're forced to. That means they understand that an ounce of prevention is worth a pound of cure. They recognize that there's such a thing as a vicious cycle when it comes to health problems, where one thing leads to another and it can spiral downwards really quickly. And this vicious cycle gets more and more vicious, if you will, the older we get, where smaller and smaller things can send you down, sometimes and and when you're in your 90s and older, often an irrecoverable cycle. So this is the typical timeline for getting help. You're fully healthy and independent. A disease or frailty begins. This could be dementia, Parkinson's, multiple sclerosis. It could just be arthritis of your hip or knee. Over time, your care needs increase. Your family, your spouse gradually transition to becoming caregivers as they help you with more and more things. At some point, the family starts to realize they need help. They think it, they probably don't say it out loud. They're just thinking, this is getting kind of tough, but I'm going to deal with it because I love this person. At some point, despite their best intentions, reality is what it is. That type of work eventually adds up and they start to burn out. At some point during this burnout process, somebody says you need to get some help. And so they actually start to look for help. And then at some point, maybe they actually get some help. And I put this here. The patient themselves usually agrees they need help long after the family realizes they need help, and they sometimes even after they actually get help. Not uncommonly, patients who are getting help will refuse the help, even though everyone else in their life agrees that they need it. And then, heaven forbid, if that help is insufficient, the patient is forced into facility-based care. What successful families do is that they get help much sooner, before they burn out, before the patient agrees they need help, because they'll never agree up front until they see the consequences of how helpful that help is. And they use it preventatively. As soon as they realize that they're transitioning to a caregiver role, they will get some help. And this is the vicious cycle you're trying to prevent. These are some of the most common minor things that precipitate a vicious cycle: a medication error, missing a dose or double taking a dose, a minor fall that causes a minor injury, a mental lapse like forgetting to close the front door and the temperature of the house goes down, or leaving the stove on, starting a fire, missing a medical appointment, missing meals, missing home maintenance, not taking care of your hygiene, and then getting an infection. Any one of these things can beget the others. It's pretty easy to see. You bum your knee, you don't go to your next medical appointment, you don't refill your meds, you therefore get an infection, your disease gets worse, your house gets more disheveled, you trip over a box, you miss a meal, and this happens over and over again until I see you in the ER. And it happens all day, every day in the ER. Now, who's ever opened a cupboard and seen this mess? So this speaks to the vicious cycle, the medication problem. Successful families do not ignore potentially hazardous situations like this. They're not overconfident. Now, I've talked to so many older adults who tell me, I know my meds, I know why I take them, I know when to take them, I know what they look like. Great, I believe you. But it's not a problem until it is a problem. And when it is a problem, you enter the vicious cycle. Okay, what better than this mess? And by the way, even when people tell me they're really good at their meds, it usually takes me 3 questions or just a brief walk around their home to identify that they actually don't. They actually don't, the vast majority of the time. Successful seniors use blister packs. Okay, we insist on them when we look after patients in the home. Blister packs keep the meds organized. They make it very clear which day you're supposed to take them. And if we come back in 2 days and we notice that you haven't taken them, and we know immediately that there's a problem, rather than in this situation where we wouldn't find out for weeks, days, weeks, months, until you've gone into some sort of organ failure or some sort of a tragic consequence of taking too much or too little of your meds. So here we find out within a day or even within a dose, and we can fix it right away. Now, this is not a perfect solution. You still have to take them. People drop their pills. They sometimes hide them. Not uncommonly, patients will pump out the blister pack and then choose which pills they want to take and throw out the rest. So it's not perfect, but it is still a much better system. And this hardly costs anything. Most pharmacies do this for free, except for the dispensing cost of their medication. One thing I'll point out here is that you should use the medicines. If you get a new blister pack on a Thursday, take it on the Thursday so that the date matches up with the actual date. Don't start at the top, because that becomes very confusing for everyone. Now, what about facilities? Now, facilities have their role, for sure. We provide services in facilities quite commonly. In fact, about a third of our business operates within facilities, so we know them quite well. We always recommend, because we have a bit of a conflict of interest in looking after patients at home, that you speak to a third party about which facility to go to. There's lots of facilities that can work for your family according to your budget, according to your needs and preferences and location. The variations between them are massive, and so we recommend you talk to a seniors care consultant. These people are worth every penny. Picking a facility, and more importantly than that, choosing not to go to a facility is a conversation you should have with an expert, and it's one of the most consequential decisions you'll ever make, of course. And so these are 3 groups that I have worked with or have met and can endorse. Some of them are here right now. So Lisa from Your Seniors Concierge. I think we have another Lisa from Proactive Seniors, as well as Susan Smed from the Advanced Agency. So if you have any questions for these folks, please do reach out to them and ask for their expertise, which again is worth every penny if this is something you're considering. So from my perspective, good reasons to move into a facility are the things that they do well, which are food and activities, if you're still able to engage in them. Downsizing, so if you're going to move from your acreage in Sundre down to Calgary to be closer to the kids, then you have to move into something, and cost is not an issue, then it's a great way to downsize. Separation for severe disease. This is a really sad but sometimes necessary situation where often a spouse living with a spouse with a very severe end-stage disease, they've come to the point where this person's no longer the person they married, or that it's just physically and mentally unbearable to live with them all day, every day anymore. So having that physical separation is necessary, usually more for the non-diseased person than the diseased person. When there are true 24-hour care needs, again, true 24-hour care doesn't even really exist in facilities, but if cost is an issue of providing true 24-hour care in the home, you can provide some version of 24-hour availability of care in a facility. This is end-stage dementia, people that wander all day, every day. You have to have someone there all the time to stop them from leaving. And the physical facility solves that problem, not the individuals, not the care team. or quadriplegia, where basically their full care, every movement, every activity of daily living requires support. And then really important too is that cost is not an issue because facilities are almost always more expensive than staying at home. These are poor reasons to move into a facility. These are often common misconceptions that cause people to consider facilities and sometimes convince them to move into facilities, but erroneously. So expecting better care just because it's more expensive, very untrue. The care is often worse, actually, in our experience. Obviously, we're a bit biased, but I will say we provide a lot of care at facilities for a reason because the families who are in these facilities are dissatisfied with the care they're getting. Believing it will prevent falls or decline, there's really nothing fundamentally different about living in a congregate living facility to your own home with respect to falls or decline. Again, the structural differences are pretty much the same. You still have bathtubs, you still have toilets. If there's stairs, again, they can be mitigated in the home in a different way. People fall at facilities all the time, perhaps even more frequently than their own homes because they're not familiar with them, and we see them in the hospital all the time. Socialization when participation is limited, meaning going to a facility to be around other people when you've already reached a stage where you're not able to enjoy that sort of thing. It doesn't make any sense. Most of the families and patients that we look after in facilities don't engage in any sort of socialization with the facility whatsoever. Assuming it will be cheaper, it's not. That's the simple answer there. The sales experience can be compelling. They took a page out of the timeshare people's books. I guess they can be very compelling. And assuming it'll be more comfortable, and this is usually a spouse or usually actually a kid talking on behalf of their parents. They say, well, wouldn't you rather be in this shiny new building rather than your old house that you've been in for 60 years? And the answer is usually no, actually. I'd rather be in my old 60-year-old house than this shiny new building. This is a graph kind of comparing your options. The cost is down here. So medically supervised home care, surprisingly for many, is actually cheaper and better from a medical point of view than even nursing homes and assisted living because the volume of care is so much higher. We're usually providing 4 to 12 hours a day, up to 24 hours a day of one-to-one bedside support, as opposed to, again, minutes to maybe 1 hour of support at the bedside at an assisted living or a nursing home. And so medically supervised home care essentially combines what traditional home care combines with the medical oversight that you'd get at a facility, and it combines it together and puts it inside your home, 100% covered by Alberta Health as far as physician services are involved. And with public funding support, the cost is markedly lower than even a public shared room long-term care. So starting at around $250 a week, which gets you a lot of care, a lot more care than you'd get at a facility. And all the things you'd get at a facility, like the cooking, cleaning, the exercises, rehab, and even investigations in the home. We just a couple of days ago, I had a patient in a facility actually who called us. They needed help with a cough. We found out they had low oxygen within the same day. Within hours, we had the patient set up with home oxygen. An X-ray was in the home. The physician home visit came to evaluate them. Family was updated. Everything was done as if she was in a facility, and probably even better, and with more follow-up and close care than she would have had if she was at a facility. And then the last thing I'll mention is that successfully aging at home for many also means dying peacefully in their own bed and surrounded by family. This is palliative care, hospice level care in the home that medically supervised home care can provide. And this is a really, really important and valuable service that we provide to patients. So with that, I'll just end with any questions. And of course, again, if you're watching this online, you can feel free to text this number for questions at any point. It is our line at HomeFree that will continue to be monitored. And I thank you for your time.